And I think policy at the moment, without change in government, has been incredible. Like to see this shift that we haven't seen in over a decade in Australia, where the government currently is taking positive steps towards, it's the biggest change in climate legislation that we've had in over a decade. And I think specifically in regards to healthcare and climate change, we now are in the government is in the development of a climate and health framework, a strategic framework that will allow alignment between all the states and territories, districts, and down to the hospital level, for everyone to be aligned in what they can do. And that's incredible. We have never had that before. That being said, as Amanda said, and so did David, this kind of positive push and agency that we want to give people, the patients, to make the right decisions. That's been a narrative that is becoming super, super strong at the moment. And again, that's going to push things forward. As we had a few weeks ago, there were up to 3,000 medical professionals campaigning against fracking in the Northern Territory. They were there at the front line saying, this is going to disrupt the health system. This is not going to be good for our patients. And that is a narrative that everybody's going to buy into, because at the end of the day, what we care about is our families and our health and our community's health. The other important thing that's happening at the moment is before Senate right now, there is a duty of care bill that's being presented. That is a climate change amendment that's being put forward. And so basically what that states, it imposes a statutory duty on decision makers to, one, consider the likely impact of decisions that could harm the climate on the health and well-being of current and future children as a paramount consideration, and two, not to make a decision that could harm the climate if the decision poses a material risk of harm to the health and well-being of current and future children in Australia. So that there is a real push for that right now. And I think the more we are aware of that, the more policy change can occur. The more communities can push for that narrative to end up in government to say, hey, this is about Australians, this is about our health. We already have an incredible healthcare system. Let's keep that going. Yeah.
David, are you seeing that on the ground? Are people very interested in this so far?
I was just thinking about that as Rashmi, and the answer is sadly not yet. It hasn't permeated to mainstream consciousness in clinical decision making.
Yeah.
And that's why we have to tread relatively carefully to preserve quality and safety. But knowledge is power.
Yeah.
And I don't say that glibly. It is it will be demanded of the system. Rashmi already talked about legislative things, and now there are competitions between Hospital A and Hospital B about which is the greener, preparing lunches and things like that. So it is permeating into consciousness. But because of the nature of the audience that are listening, I've learned so much about this in the last couple of years, because this is truly a space where multidisciplinary research, I know everyone says multidisciplinary research is great, but this is a space where it won't happen without people crossing out of their silos. So people from my hospital working with the Sydney Environment Institute, working with the Faculty of Science, working with economists, working with policy people. That's how it's going to happen. And just as an example of something that's really important, we do have to establish a standard methodology. So, for example, if I want to know, I did an operation on someone this morning to close a hole in their heart. And if I want to know what the carbon cost of that is, I can have someone come in and say, well, you opened this pack and 3 people drove in from their homes and this is how long the electricity was on, and that cost 120 kilojoules or something. But the better way to do it is to say, you do 200 of these a year, David, and the whole endeavour for the entire year costs this, and you've got to divide that by 200. And you get very, very different numbers as to whether you look at the carbon cost of an individual procedure or you look at the carbon cost of an entire entity and divide it by the number of procedures. You can get a 10-fold difference in the absolute number of the environmental impact. So just a plea, and this is such early days in this field, it's really, and we've got to have a standard methodology that everyone accepts. And if that's reporting 2 numbers, the sort of case by case versus the entirety, then so be it. But I think the answer to your question is we're still a long way from home about this kind of information starting to have an impact.
Yeah, actually, on that note, Amanda, where are those types of differences coming from in the data, and why is the method you're currently working with the one that we're advocating for being taken up by more clinicians?
I think I would say that there are two methodologies that David's alluding to, and both of them are good, and both of them serve a purpose. They answer different questions. So the idea of someone working out how long the operating theatre was running for and what products you used, and calculating for each unit of, I don't know, whatever the things you're using when you do that, how much carbon was generated to create that one particular thing. That's generally using a methodology called life cycle assessment. The limitation with that assessment is that you can only go so far back in the supply chain. So let's say it was forceps. I don't know. Yes? Okay, good. I'm learning lots. It goes both ways. Let's say it was forceps. We can say this is how much carbon was embedded in the manufacture of those forceps. But do we know how much carbon was embedded in the manufacture of the machinery that made the forceps, and how much carbon was embedded in the sheet metal that went into making that machine, all the way back to the iron ore when it was dug out of the Pilbara in Australia? So the life cycle assessment by default has to have a boundary. When we move from tracing the physical units and start looking at the monetary units, that enables us to look at the whole economy. And as I mentioned before, as a society, we like to know where our money goes. So there is a lot of information out there that enables us to track those interconnections between the economy. There are limitations with that as well, because we actually can't tell the difference between this brand of forceps and that brand of forceps, because we're relying on the resolution of the economic data. So in answer to your question, I think you actually need to say which methodology helps you answer which question, and what information do we have. Now, in an ideal world, if we decided as a society that we want to be able to account for our carbon or our biodiversity loss or social impacts as well as we account for our money, there's actually no reason why we can't track it at that level of detail. We just choose not to. The statisticians pick up data on, the ABS sends out surveys to companies on their money. How much money did they make? How much money did they spend? Companies have to report their greenhouse gas emissions, but only if they are huge contributors to greenhouse gases. So if we as a society decided that this was important enough to track, we could choose to measure as well. And so I think ultimately that would be amazing, and then we wouldn't have to sort of worry about the limitations on the edge of both of these methodologies, and both of them would help us answer the questions that we need to be able to answer to know which choices to make.
Wouldn't that be brilliant, having all of that data to help inform those decisions? I think, though, we are saying that there is not enough interest from clinicians. How do you want to get them more interested beyond just getting that data to tell that story?
I think it's getting the data.
Yeah.
And also I think things might be imposed on us. For example, I'm told appropriately, regularly, that I can only do a certain number of procedures a year, and that will then exceed the budget. So professionals in all walks of life are used to having limitations on what they've done, but in healthcare, for the reasons Amanda articulated, because it's a virtuous profession, you tend not to place limits on it. But it is very hard to sit in front of an individual and have the economic wherewithal to provide them with the numero uno treatment, but to pull back from that for reasons of carbon emission. So it is a complex thing, but the first thing is to generate the data.
Yeah.
And there truly are a lot of examples where you can arrive at the point where you want to be by several different pathways.
I guess then, Rashmi, once we have that data, how do you think we can best influence change?
I think I have a little bit of a different perspective on this, because I think we have enough data to make decisions on my side of the coin. We know enough of the health impacts of emissions from certain sectors. We know enough. In fact, we know too much at this point. I think I've got here, we have the methodology to say, from the air pollution from this coal station, this many people died, this many premature deaths happened, this many people, I think it was 14,500 cases of childhood asthma from each of those coal stations at an average. So we know this information enough to make decisions. I think what is lacking is good governance, and it's not coherent enough. It's knowing this and not doing it. It's kind of, we think now back just to the biggest example we can have in terms of a crisis in health from COVID-19. Did we know about pandemics before? We sure did. That wasn't new information as much as we'd like to pretend it was. We knew what hygienic behaviors we needed to implement. We knew that we needed to talk to behavioral scientists to make sure that our infrastructure and our social structure was ready. That wasn't new. In terms of what was missing, to me on my side, is not so much data and information, it's governance. It's decision makers taking up that information, listening to clinicians, listening to academics, understanding people are working on this issue, and when they say, hey, here is my expertise, please take it forward, do something because you're in a position of power, there's no accountability, and that is what's lacking.